Hi, good evening everyone. As I told you that I am going to discuss the ASRA guidelines in detail. So today's topic of discussion is ASRA, and we recently got an update last year, that is the 5th edition of ASRA, and I am going to send the PDF of this 5th edition ASRA guidelines on the group. You can go through it. It will take some time for you to go through the entire PDF, the entire article. But trust me, the way they deal with the stuff, the way they describe a drug, all the antiplatelet agent, all the anticoagulants, everything, even the pharmacology can be amazingly written with what ASRA has given. So ASRA has worked really very hard. It is American Society of Regional Anesthesia and Pain Management, pain medicine evidence-based guidelines, and we often talk about ASRA, and it is very specific to what happens during a neuraxial block, which is either spinal or an epidural catheter, or a deep plexus block, or a deep peripheral nerve block. So I am going to define all those things, and what I am doing is, for the first time, I am reviewing an article. So apart from the fact that if ASRA guidelines will come, then you will have to write the perioperative management of patients based on ASRA and how you are going to control the drugs. But I am going to discuss what is their methodology, what they did, what was their concept, and everything about it. So you should know how detailed review happens when these guys, they want to put up a guideline, right? And it is not based on hearsay. So let's first discuss what is different between ASRA 4th edition versus ASRA 5th edition. So because this is the part that you don't have to write in the exam, so I've just written it down, and this PDF will be available for you to go through. And you can give very intelligent answers to your examiners if they ask you, ki, okay, what is difference and why do they keep updating every few years. So this is more reorganized and it is condensed. The 5th edition follows previous methodology, but it is more concise. So now they have better data to back up what they are saying. There is an update in the terminology, and this is the part that you will have to remember and use. Earlier, we used to use the dosing as prophylactic and therapeutic dose. Prophylactic is when you are using the dose for prophylaxis, versus therapeutic when you are using it for the treatment of venous thromboembolism, right? But now they have shifted it to low dose, high dose. The reason is very simple. A low dose for someone can be a high dose for someone else. So it has to be based on dosing. Suppose you are giving edoxaban, or rather not edoxaban, rivaroxaban. Suppose you are giving rivaroxaban to a patient, and it is according to you, it's a low dose DOAC, but that patient has renal failure, so it's clear his creatinine clearance is less than 50. So automatically that low dose will become a high dose. So idea is that you should know the final outcome, considering the age, the comorbidity, the different types of drugs that the patient is taking. And I am going to talk about what are the factors that can convert a low dose into high dose. So we have removed the terminology prophylactic therapeutic, and we have now introduced low dose, high dose. It has a conservative approach, and I told you in the last video as well that ACCP guidelines are more pro antithrombotic, while this is more, what you can say, anti-hemorrhagic, right? So recommendation prioritize patient safety and propose a longer interruption time before neuraxial anesthesia. And this time what they have done is they have integrated their guidelines with ACCP, European Society of Regional Anesthetists, and European Society of the Association of Cardiology, and they have tried to align the recommendations with them, because they also felt the need that there are too many societies talking about too many stuff. So let's try and regularize it, right? So this is what is different in the 5th edition as compared to the 4th edition. Now, this is an old way of talking about any guideline, and that is your level of evidence LOE and the strength of recommendation SSOR, strength of recommendation. Level of evidence is considered class 1 when you have RCTs or you have meta-analysis backing up your treatment or your intervention. When it is based on observational or epidemiological studies, epidemiological series, then it is considered as level of evidence 2. And 3 is when it is based on case reports or expert opinion. Case reports and expert opinion. And although level of evidence class 1 is what is considered to be very good, level of evidence class 1 is what we consider as standard, but you might be knowing that in India most of the time your consultants will say, because I say so, because I've seen it over the years. So in India we often consider 3 as better, but based on the scientific temper of study, it is always class 1 which is considered to be the best. And then what is the strength of recommendation in this evidence? So the strength of recommendation is if everybody agrees to it, general agreement, it is strength of recommendation A. B is when there are conflicting opinions. And C is when it is not useful or even possibly harmful. So why am I telling you? Because in a guideline, any guideline, they will always tell you that what is the parameter they have used to give their recommendation. So when ASRA says we recommend, it is talking about more robust data. So when it says we recommend, it uses stronger level of evidence and strength of recommendation like 1A, 2A, 3A. 1A, 2A, 3A. Sorry. 1A, 1B, 1C. The strength of recommendation would be strong. 1A, based on RCT meta-analysis, general agreement, based on RCT meta-analysis, conflicting opinion, based on RCT meta-analysis, not useful or even possibly harmful. When the ASRA says we suggest, then they use weaker level of recommendation, that is 2A, 2B, 2C. And most of the places you will see the words we suggest rather than we recommend when you go into the guidelines, right? So ASRA says we recommend, we suggest. We recommend is strong 1A, 2A, 1A, 1B, 1C, and we suggest is weaker 2A, 2B, and 2C. All right. So this is about the starting point of what ASRA is saying, and I'm actually quoting the entire article in the way it is being written. So it's like a review of the article. Let's talk about general recommendations for regional anesthesia and anticoagulated patients. So hemorrhagic complications are rare, but they are catastrophic because it is close space bleeding, spinal canal, Schwarz compartment. Risk stratification approach is used where neuraxial block or deep plexus or peripheral block are considered as high bleeding risk. Remember, in the last session, I told you about risk of thromboembolism and risk of bleeding, and nowhere I mentioned neuraxial anesthesia because neuraxial, the entire guidelines are different. So we are talking about it specifically here, and all neuraxial blocks or deep or peripheral plexus, deep plexus or peripheral nerve blocks are considered high risk of bleeding. What are they? I'll talk to you in some time. Conservative time intervals are recommended to ensure complete anticoagulation resolution. Now, idea is you are stopping to prevent a close space bleeding, so the in time intervals have to be based on the pharmacokinetics of the drug. Now, the new thing that they have introduced in the current recommendation is the using of drug specific assays. So when you are using direct oral anticoagulants, then anti-10A level and thrombin time can help you assess the residual anticoagulant activity. And what is the threshold for safe procedure? So suppose you are wanting to give a neuraxial block or a epidural catheter insertion before the recommended time interval, or the patient's renal status is very bad and now you're not sure how much that action would be. So you can do a drug specific assay where you can calculate the plasma levels of anti-10A that should be less than 30 nanogram per ml, or anti-10A activity, which is a surrogate marker where you use different reagents to look at the activity of anti-10A, should be less than 0.1 international units per ml. And this is something I want you to write in your answer. If there is ASRA recommendations that are asked in the exam, I want you to write these things. That use of drug specific assay for direct oral anticoagulants has been promoted and the criteria has been laid down. It has been set down for ASRA 5th edition. If you compare with the ACCP guideline, there they have an integration. So now they know and they have mentioned what ACCP says. ACCP is American College of Chest Physicians and antithrombotic. Their guidelines are more antithrombotic. So they are not worried about the spinal canal bleeding. So they have shorter anticoagulant interruption times, while ASRA remains more anti-hemorrhagic. As an anesthetist, we should always focus on more anti-hemorrhagic rather than anti-thrombotic. So it favors longer drug-free intervals before neuraxial blocks. Now, DOAC interruption times differ. ACCP recommends shorter interruptions, while ASRA has more conservative approach. That is the comparison with ACCP guidelines. All right. Let's now talk about the concept for management. Concept. Now, this is the entire thing that they have given in the beginning of the article, and this is what I want you to remember very nicely, that why have they made these guidelines. All right. Let's first define. So because ASRA is a society for regional anesthetists of the America or of the world, therefore you have to first define what are they trying to do. They are trying to talk about guidelines for neuraxial anesthesia or neuraxial block includes spinal and epidural catheter. And we often say, na, ki, sir, the ASRA guidelines is for epidural catheter. No, it is for both spinal and epidural. Because in both you are going to put the needle in a closed space where if there is a bleeding that happens, although the risk with spinal is lesser, but they are not trying to, kind of compare between the two. So it talks about neuraxial. And when we say deep plexus or deep peripheral techniques, peripheral nerve blocks, then exactly which nerve blocks are we talking about? So you have stellate ganglion block, infraclavicular is pretty deep. Then you have lumbar sympathectomy or lumbar sympathetic block, as well as lumbar plexus block. And paravertebral block is also considered to be a deep plexus block. And the list is not limited to this, but this is what ASRA has given in its article. All right. But the list is not limited to this. All right. So let's first define. So what we have defined what is neuraxial anesthesia. We have defined deep plexus or deep peripheral nerve block. I'm going slow, so don't get bored, right? Let's talk about goals. Why is ASRA doing this thing? Is there a reason why ASRA wants to do these things? What is that they are trying to achieve? So they are trying to minimize peri-procedural thrombosis. They are also trying to minimize peri-procedural bleeding, peri-procedural mortality, peri-procedural inconvenience, and peri-procedural economic burden. So somebody asks you, we have already seen in the last session, whenever somebody is on anticoagulants versus antiplatelets, then basically there is a risk of bleeding versus thromboembolism for anticoagulants, bleeding versus risk of cardiovascular morbidity, mortality in antiplatelets. And the same thing happens here also. Here, high risk of bleeding. All these things are based on high risk of bleeding. Why? Because neuraxial and deep plexus are high risk for bleeding. But ultimately, they want to decrease the risk of periprocedural thrombosis, bleeding, mortality, inconvenience, as well as economic burden to the patient. Let's talk about pharmacological basis of management. So it has to have a concept. It has to have some calculation. Why stopping for such time? Why stopping for that time? So the first is how they have defined the dose. So there is a low dose now versus an high dose, a high dose. And we have previously said prophylactic versus therapeutic. But why they have changed it to low versus high? Because factors affecting action. Factors affecting action. These are the factors that can convert a low dose into a high dose. They can convert a low dose into a high dose. How can they do that? Suppose there is decreased renal function, which we talk about the most. And this is based on creatinine clearance. Then low body weight, which we rarely consider. But if you have cancer patients who are very cachexic, who have very low body weight, then this is something which becomes pretty significant. Then advanced age. And then there are certain drugs. All right. Now, there are certain drugs that affect GP glycoprotein, the glycoprotein inhibition. So drugs affecting glycoprotein inhibition. And these drugs will increase the duration of action, like cyclosporin, like ketoconazole, like erythromycin, like dronedrone. All right. So the first is what is a low dose versus what is a high dose. Low dose versus high dose. So any drug can, when given with the concept of being a low dose, can be considered as high dose, and so the duration of stopping should prolong, because then the risk of bleeding would be for a longer period of time. And these are the things that you should consider. The first three are most important, that is renal function, body weight, advanced age. And in drugs, of course, cyclosporin, ketoconazole is something which is very commonly given, and erythromycin now not used too much, and dronedrone is not also a very a drug that is used very commonly, right? So this is what you're supposed to look at first. Now, the concept, and this is, I'm sure nobody has ever spoken to you about this thing, and you might be wondering, ki, sir, why we need to stop heparin for 4 to 6 hours, but warfarin for 5 days and aspirin for 5 days. And the idea is very simple. The idea is very, very simple. The timing of discontinuation depends on the dose that you are giving, and if you are giving a low dose, then the timing for discontinuation is twice the T half. The time it requires for the drug concentration to become half in blood. Twice amount of that. Because in first 50% of drug would get excreted. In the second T half, remaining 50 ka 25%. So effectively 75% of drug is excreted. And when you are giving in low dose, it blocks less number of receptors. So 75% drug elimination ensures effective coagulation. But if you are giving in high doses treatment, then because you are using high dose, the receptors are more avidly, they are bound to the drug. So now you require 5 times the T half. 5 times the T half. So almost 95% of drug will get eliminated. That is your criteria. What is time of discontinuation before putting spinal or epidural? Now, how they calculate T half? T half can change in different situations. So they will take the longest T half for an individual. Longest T half is in patients with renal insufficiency. So on the safer side, they will take the T half of the drug in a patient with renal insufficiency, and that is what they will use to calculate these timing of discontinuation. So what is the time of discontinuation? Low dose, high dose, low dose twice the T half, high dose 5 times the T half. But time of first dose after the block or catheter removal. Now this is something that you have to resume later on. So what is the concept behind time of first dose after the block? Now you remember, suppose you have stopped a drug 24 hours before the surgery. All right. So you wanted to give spinal, you wanted to give it tomorrow at say 3 p.m. So you stopped it 24 hours before the surgery. So today after 3 p.m. you will not take that drug. So tomorrow 3 p.m. 24 hours have passed and now you have put the needle in the back. All right. Now when there is spinal, it is fine. Then post-operatively, whenever the hemostasis is achieved, you are pretty much okay with everything. Then you can restart. But suppose there is an epidural catheter. So while the catheter is in situ, you never try to give another dose of anticoagulant or antiplatelet medication, because then there can be spontaneous bleed inside because of the catheter, which can cause epidural hematoma. So suppose you remove the catheter on next day at morning 9 o'clock, then how much time after removal of catheter you should give the first dose? Why? Because you have to understand, suppose when you remove the catheter there is bleeding. So you need to know that in how much time the drug action will start, peak action, and how much time it normally takes for the clot strength to become good. So normal time for clot strength is 8 hours. And the time that you require for the drug action to peak, you will minus that in 8 hours. That is the duration that you have to wait before you give the next dose, right? So the idea is time to clot formation, time to maximum clot strength minus peak anticoagulant effect. Which is called as Tmax. Normally time to maximum clot strength is 8 minus peak anticoagulant effect Tmax is 2 hours for commonly used DOACs. And that is why you will always see that it is usually 6 hours after the catheter removal that you can give the next dose. 6 hours after catheter removal. But in this is so based on the pharmacokinetics. But again, the pharmacokinetics will change whether you are using it in patients with high risk of bleeding or low risk of bleeding, right? So now what is EHRA, European Heart Rhythm Association, EHRA recommendation for post-operative resumption of DOAC. And this is something I am telling you so that you remember the general concept, because when we practice, in our practice, there is absolutely no urgency most of the time to resume the post-operative. So you follow these guidelines that if there is a low or moderate risk of bleeding, then you will start after 24 hours. But if there is a high risk of bleeding, then you will start after 48 hours. Post-op resumption of DOAC. Okay. So if it is a low or moderate risk of bleeding, 24 hours. And if it is high risk of bleeding, 48 hours. Okay. perioperative VTE risk management. So now let's come to what ASRA says. So ASRA mein risk stratification for VTE prevention is based on, in medical patients, there are two scores that they use, Padua and improve scores for medical patients, and in surgical patients, Caprini. I'm not going to go into the details. Nobody will expect you to know these things. Okay. So remember here risk stratification, there we used for thromboembolism, CHAD, S2, VAC, and for bleeding we used HAS-BLED. Here for VTE, we will use in medical patients who are not going for surgery, Padua and improve. So you'll say, sir, if they are not going for surgery, why are we talking about it? Because they can still call you for a lumbar puncture. They can call you for a lumbar puncture, and you will have to manage this in the same way because it is ultimately putting needle in the back. So there can be a medical patient who is not for surgery where lumbar puncture is indicated, and that is why you need to remember there for medical patients we use Padua and improve. For bleeding, we use a improve bleeding tool that I will show. For surgical patients, you have Caprini. Now you will say, sir, why they are using different guideline? This is different guideline because they are looking from the perspective of a non-cardiac surgery. So they are looking at their risk patients, patients with mechanical heart valves, with atrial fibrillation, with previous history of VTE. So they are using their method. Here we are talking about patients who are posted for surgery. So whatever reason might that be, because it is a neuraxial anesthesia, they are using Padua improve for some medical patients and Caprini for surgical patients. Now what is the guidance? High bleeding risk procedure, resume anticoagulation after 48 hours. Low to moderate, resume after 24 hours. That is what I told you, EHRA guidelines. What is Padua and improve? So Padua, improve, they are almost the same. Active cancer, prior VTE, reduced mobility, thrombophilia, recent trauma surgery, age more than 70, heart rate, heart or respiratory failure, acute MI, acute infection, rheumatology, obesity, hormonal therapy, high thrombosis risk is more than 4. Improve bleeding tool is when you use certain criteria like age, gender, renal function test, cancer, rheumatic disease, central venous catheter, ICU stay, hepatic failure. Very similar to improve, but this is for bleeding, and this is for bleeding, and here improve more than or equal to 7 is high risk of bleeding. High risk of bleeding. More than or equal to 7 is high risk of bleeding. Okay. Now VTE, venous thromboembolism, it can be managed or it can be prevented by 3 methods. So VTE management can be by 3. One can be pneumatic compression devices. One is medications, and you have pneumatic devices plus medications. Pneumatic devices plus medications. Now where to use pneumatic compression devices? So remember, you are not using medication. VTE का medication anticoagulation. Anticoagulation का side effect bleeding. So if you have high risk of bleeding with low risk of thromboembolism, then you will go for pneumatic compression devices. So if you have a Padua score more than or equal to 4, not low risk of thromboembolism, high risk of thromboembolism with less risk of bleeding. I'm sorry. When you have high risk of bleeding, that is improve bleeding score more than 7, then you will always go for pneumatic compression devices. You would want to avoid VTE. When you have Padua more than 4 and you have improv bleeding less than 7, then you will go for both. Pharmacological VTE prophylaxis along with, of course, pneumatic compression devices. All right. So this is the concept. Now again, the same thing that I told you: high risk category, moderate risk category, low risk category for VTE. 3 things: mechanical heart valve, atrial fibrillation, VTE, all the things that we discussed in the last session. Okay. Now comes the main part. Now this main part is what scares us the most. And my job as a teacher to you is, one, to tell you the entire details and then to simplify things for you. So the next few tables are in entirety what is written as a recommendation in the ASRA 5th edition guidelines. Okay? But at the end, I have given a time-based approach, which is more practical to what you want to hear. It is more practical to what you want to hear. All right. So let's start with the management of anticoagulants in neuraxial or deep plexus block. So now you have defined everything. You spoke about kya ASRA karna chahta hai, what is the methodology it is following, what is the improvement from the last edition, what is the concept between time of discontinuation to the first dose after catheter removal, and you have understood all the scales, all the scores that it has used. If there is a medical patient, it uses Padua, improve to assess the risk of VTE. If it is a surgical patient, then Caprini. And there is also one thing: if there is an active cancer patient, then there is another scale that they use called as Khurana. So just remember the name Khurana. So Khurana is when you have an active cancer patient and you want to assess the risk of VTE. For bleeding, it uses improved bleeding tool. All right. And after all of this, then finally it comes to the management. So let's start with anticoagulants. So the anticoagulants are 4. There is a DTI, direct thrombin inhibitor, by the name dabigatran, while there are factor 10 inhibitors like apixaban, edoxaban, rivaroxaban. Out of which edoxaban is straightforward. You only give, the indication for edoxaban is always high dose only. But for apixaban and rivaroxaban, you have high low. Dabigatran, very specific, because in renal failure, the duration of action prolongs a lot. So let's start with apixaban. So apixaban, when given high dose, you have to stop for more than 72 hours before you put the neuraxial block or deep plexus block. Plasma level, check if you are wanting to use a lesser time interval. Catheter removal more than 24 hours before first post-operative dose. At least 24 hours should have passed. Post removal waiting time, withhold more than 72 hours if unanticipated administration. Okay. And remarks: plasma level again less than 30 nanogram or anti-TANA less than 0.1 international unit per ml. Okay. Understood? 72 hours, 24 hours. What you have to remember, 2 figures. Apixaban, high dose, 72 hours of stopping before the surgery, 24 hours to wait after catheter removal. But if it is low dose, then 36 and 6. 36 and 6. So stop for 36 or more. Check the level only if less than 36. After catheter removal, next dose more than 6 hours, and withhold. And if there is unanticipated administration, then you withhold the next dose for more than 36 hours. Edoxaban, always given in high, again 70 to 24. Rivaroxaban. Now rivaroxaban, high dose 70 to 24. Standard what we used for apixaban, edoxaban, high dose. But if there is rivaroxaban, low dose, then 24 hours, and of course post catheter removal 6 hours. But if the creatinine clearance is less than 30 ml per minute, matlab severe renal failure, then that becomes 30 hours. So the extra thing that you have to remember in rivaroxaban is 30 years. Now dabigatran. So dabigatran will depend on creatinine clearance. If the creatinine clearance is normal, more than 50 ml per minute, 72 hours, 24 hours. But if it is less than 50, that is 30 to 49, then 120 hours. And this is the highest amongst anticoagulants. Remember, highest amongst anticoagulants in the DOACs, not the vitamin K antagonist, is more than 120 hours. That means you have to stop for 5 days. Dabigatran high dose with creatinine clearance low has to be hold for 120 hours. Low again 48 6 hours. 48 6 hours. All right. Key points: plasma level, residual plasma level less than 30 nanogram per ml, anti-10A activity assay less than 0.1 international unit per ml. Renal function, dabigatran has stricter timelines for patient with impacted renal functions, and newer recommendations are most suggestions regarding acceptable plasma levels and catheter removal waiting periods are newly included. So this is about anticoagulants, and specifically the directly acting oral anticoagulants, that is DOACs. Now let's come to the standard, that is your unfractionated heparin. Now there is very limited indication for unfractionated heparin. Most of the time unfractionated heparin will be used as a bridging. So that is why if you are giving intravenous heparin pre-op, then discontinue 4 to 6 hours. No change in the recommendation. If you are giving post-op, then at least 1 hour after the needle placement. So if you have given spinal epidural, at least 1 hour after that. But if you have an indwelling catheter, they never tell you to give heparin. Okay. Now continuous IV heparin with catheter in situ is not recommended. So you don't think कि अगर आपने catheter डाल दिया तो उसके बाद आप heparin दे सकते हो. If there is bloody or difficult neuraxial attempt in the cover of heparin, then it doesn't mandate you to cancel the case. Discuss the risk benefit ratio with the surgeon. Cardiac surgery with full anticoagulation, you are not recommended to put an epidural catheter. Remember, if it is on pump CABG with full anticoagulation, don't put an epidural catheter. Okay. Subcutaneous heparin low dose, again 4 to 6 hours. Subcutaneous heparin high dose or a total dose less than 20 unit per day, again more than 12 hours. But subcutaneous high dose more than the entire day is 20,000 unit, 24 hours. So according to the dose it will change. So intravenous heparin pre-op, post-op 4 to 6 hours, more than 1 hour. ठीक? But if you have subcutaneous heparin low dose 4 to 6 hours, high dose, it depends what is the dose, 7500 to 10,000 unit BD or less than 20,000 unit in entire day, multiple doses, 12 hours. More than 20,000 unit in entire day, more than 24 hours. Post-op low dose unfractionated heparin catheter removal 4 to 6 hours after administration of the last dose. Post-op high dose unfractionated heparin, risk benefit required to enhance neurological monitoring. So neurological monitoring has to be done for 48 hours to understand. Then if there is a kind of what you can say, there is an epidural hematoma, then you will have to watch for it, right? So remember here the durations are 4 to 6, 1 hour, and 4 to 6, 12 and 24. 12 and 24 nobody is going to ask because subcutaneous heparin high doses we don't use. If you are wanting to take that much amount of effect, then you would probably start considering low molecular weight heparins. So let's come to low molecular weight heparins. So I told you low dose, high dose, that is the new definition in ASRA. But what is low dose and high dose? So you should have an idea, because in your pregnant females, in patients where orthopedic surgery is done, this is what is going to be used. So low dose is enoxaparin 40 milligrams per day or enoxaparin 30 milligram BD. Dalteparin 5000 international unit per day. This is considered as low dose, low molecular weight heparin. What is high dose? When enoxaparin is given 1 mg per kg every 12 hours or 1.5 mg per kg daily, or dalteparin 120 international unit per kg every 12 hours or 200 international unit per kg daily, and tinzaparin 175 international unit per kg daily. This is high dose low molecular weight heparin. So this is the X factor that I want to create in you guys, because we talk about guidelines, but nobody talks about what is low dose, what is high dose. Now you are the people who will know what is low dose, high dose. Even if you don't remember high dose, chalega. But low dose, you should remember enoxaparin 40 milligram per day, enoxaparin 30 milligram BD, and dalteparin 5000 international units per day. If your patient is on this, then your period of stopping is based on this particular duration that we are going to discuss now. All right. All right. Let's talk about low molecular weight heparins. So low molecular weight heparins, we know we have enoxaparin, we have dalteparin, we have tinzaparin as low molecular weight heparins. So pre-operatively, if you are giving low molecular weight heparin, low dose, standard 12 hours you have to wait. And if you are giving pre-operative low molecular weight heparin, high dose, 24 hours. Post-operative low molecular weight heparin with antiplatelet or other anticoagulant agent, you avoid use with neuraxial catheter in situ. So if your catheter in place, then don't try to mix everything together. But if you have a post-op low molecular weight which is in low dose BD form, first dose would be more than 24 hours post catheter placement. More than 12 hours. Okay? But if you have a post-operative low molecular weight heparin, single dose, low dose, then first dose 24 hours after catheter placement, but the next dose would be more than 24 hours after first dose. Understood? And post-op low molecular weight heparin therapeutic dosing, resume low molecular weight heparin 24 hours post low bleeding risk surgery and 48 to 72 hours post high bleeding risk surgery. So 1224 is what you commonly remember. There is no indication, and you should avoid if the catheter is in place, giving post-op LMWH along with antiplatelet anticoagulant. ऐसा पूरा anticoagulate मत कर दो patient को. Post-op low dose BD dosing, wait 12 hours after catheter placement. OD dosing, first dose 12 hours. Next dose would be 24 hours after the first dose. And post-op, if you are starting low molecular weight heparin therapeutic, then low risk of bleeding, wait for 24 hours, high risk of bleeding, 48 to 72 hours. Now, there is a very unique drug called as fondaparinux. Now, fondaparinux is a parenteral anti-10 agent. Normally, we have oral anticoagulants, right? This is parenteral. And why am I discussing it? Although it's a anticoagulant, but I'm discussing it because of its fast onset, short duration of action. It is one of the very important drugs. Excuse me. It is one of the very important drugs that is used to replace low molecular weight heparins or heparins, unfractionated heparins in patients with heparin-induced thrombocytopenia, HIT. So that is why fondaparinux is very, very important. Fast onset, short duration of action. Suppose the patient is taking low dose of fondaparinux, 2.5 mg once daily. Then hold 36 to 42 hours in healthy patients, okay, and 58 hours in moderate renal insufficiency. All right, right? So low dose fondaparinux, 36 to 42 healthy normal, 58 in renal insufficiency. Severe renal impairment में अगर आप low dose fondaparinux दे रहे हो, creatinine clearance less than 30 ml per minute, then you have to avoid neuraxial or deep plexus block. It is not a good drug if you have severe renal impairment. Doesn't matter low dose, high dose. But if it is high dose, 5 to 10 milligram once daily, then hold for 70 hours in young, 105 in elderly. और ये सबसे weird है. All the other guidelines are either 6, 12, 24, 48, 72, 120. All in the multiples of the day. But this is the only drug where there is some deviation, 70 and 105, which is very weird. But it is, I think, based on really sorry. I think it is based on pharmacokinetics. So now it becomes a very important point for you to remember कि जो exception है वो सिर्फ एक ही drug का है, that is fondaparinux, high dose, young patient 70 hours, elderly patient 105 hours. This figure is not overlapping with any other drug. And catheter removal at least 6 hours before the first post-operative dose. Now NSAIDs has a very standard recommendation. According to ASRA, there is no contraindications to NSAIDs, and that includes aspirin. That includes your COX-2 inhibitors as well. So no added risk for neuraxial block. So what we do for spinal anesthesia, what we do for hernia surgeries, we have to give spinal and we wait for 5 days. We tell the patient is currently unfit for surgery, stop aspirin. You have to stop clopidogrel, but there is nothing that says that you have to stop aspirin. Then you have thienopyridines, that is clopidogrel, prasugrel. So clopidogrel 5 to 7 days, prasugrel is a longer acting 7 to 10 days. Ticagrelor, which is also a GP2B3A inhibitor, which is for stopped for 5 days. Warf. Now warf is a vitamin K antagonist, and we know the standard of warf is INR. So you hold for 5 days, confirm INR normalization, it has to be less than 1.5 for everything. Discontinue 5 days INR normalization, INR monitoring daily with indwelling catheters, and catheter removal only when INR is less than 1.5. Where not to give spinal or epidural? 1. Fondaparinux, severe renal impairment. Fondaparinux, severe renal impairment, don't give spinal epidural. ठीक? Unfractionated heparin with full anticoagulation, which is done in cardiac surgery, don't give heparin. Parenteral thrombin inhibitors. Parenteral thrombin inhibitors are argatroban, bivalirudin, decirodin. No, don't give spinal anesthesia. Don't give epidural catheter, right? So 3 places where you would avoid the procedure because of the drug. Otherwise, we control the drug for the procedure. So nobody is saying don't give spinal epidural. But 3 places where we want to avoid spinal epidural: direct thrombin inhibitors, parenteral thrombin inhibitors, argatroban, bivalirudin, decirodin. Unfractionated heparin, full anticoagulation, cardiac surgery. Fondaparinux, severe renal impairment. ठीक? So this is the part that is for the ASRA. What ASRA has told. Okay. This is what ASRA has told. Now in this, one thing is thrombolytics and fibrinolytics. And that is again a very debatable, although they have given it in the guidelines. बट जिसको फ्रैंकली थ्रोम्बोलाइटिक्स दिया है उसमें तो स्पाइनल एपिड्यूरल करना ही नहीं है, बिकॉज थ्रोम्बोलाइटिक्स इज जनरली गिवन फॉर myocardial infarction. But the question that came is, what if somebody is having a spinal or an epidural, surgery is going on and he gets a myocardial infarction? तब तो फिर आपको thrombolytics देने पड़ेंगे, तो क्या करना है? तो let's talk about thrombolytics. Let's talk about thrombolytics. So ideally there is no puncture of non-compressible vessels for 10 days when thrombolytics have been given. So no needle placement of non-compressible vessels for 10 days. नॉन कंप्रेसिबल वेसल्स को 10 डेज तक थ्रोम्बोलाइटिक्स के बाद आप स्पाइनल एपिड्यूरल करोगे ही नहीं. ठीक है, तो ये तो हो गया व्हेन यू हैव गिवन थ्रोम्बोलाइटिक्स. यू कैन ओनली प्लेस निडल आफ्टर 48 hours when you have confirmed normal fibrinogen levels, which is the last step of the coagulation that comes back last. ठीक है, so if you are giving a needle placement, then you have to wait at least 48 hours and then confirm diagnostically normal fibrinogen level. ठीक, now neuraxial block and thrombolytics में क्या करेंगे? Ideally तो you don't want to give, but suppose there is a neuraxial block, there is a catheter in situ and you have given the thrombolytics. So two things. First is don't remove the catheter. don't remove the catheter, and then do frequent neurological monitoring. Frequent neurological monitoring. All right. Frequent neurological monitoring, at least every 2 hours for 48 hours after last dose. This is for thrombolytics. Although my general take on thrombolytics is देना तो है ही नहीं, सवाल ही नहीं पैदा होता. अगर आपने thrombolysis किया है तो 10 days तक no spinal epidural, no deep plexus block. If at all you want to put the needle, confirm normal fibrinogen level, but at least you have to wait for 48 hours. Suppose there is a catheter in place and you have given a thrombolytic agent, then don't remove the catheter. Suppose you have given spinal and you have given thrombolytic agent, then you have to do neurological monitoring. कि अगर हुआ तो then you will have to open it up. So these are the guidelines, and this is where I have tried to get the extract of what ASRA wanted to say and give it to you. Okay. Now pregnancy may, they have given a very good note, and they have said that pregnancy inherently is a state which is more procoagulant than anticoagulant. So the guideline should be little lesser, and there is very less chance of spinal epidural hematoma. But because we don't have robust data, so whatever we have followed in this particular guideline will be applicable to the pregnant women. So there is nothing different for a pregnant woman. Now I have to bring something new for you, isn't it? So what I have done is I have given a time-based approach. I gave you drug-based approach. So we discussed anticoagulants, then we discussed antiplatelets, then we discussed vitamin K antagonists, we discussed parenteral thrombin inhibitors. So we discussed drug-based. Now let's talk about duration-based. And this is what you have to remember, because this is what is going to help you in the practice. And this is my USP for you for this class. Okay? No stoppage for NSAIDs, which includes aspirin, ibuprofen, diclo, ketorolac, naproxen, COX-2 inhibitors. Everything has to be continued. Now very unique is an antiplatelet agent by the name cangrelor, which is also used for bridging antiplatelet. That has to be stopped for 3 hours. Now this is a little weird, but 3 hours. Resume after 8 hours post catheter removal. Then you know unfractionated heparin is 4 to 6 hours. 4 to 8 hours is eptifibatide and tirofiban. Again, two antiplatelets, which are IV antiplatelets, which are used by the cardiologist. So 4 to 6 hours of stoppage of eptifibatide and tirofiban. And remember, antiplatelet agents अगर दिया है, मतलब अगर किसी का coronary angiography plasty हुआ है तो उसको epidural you would not put spinal epidural for at least 4 weeks post surgery. Okay. Then 12 hours is low molecular weight. 12 hours is low molecular weight heparin, which is low dose, and subcutaneous heparin, which is high dose. So 12 hours is enough. 24 hours is low molecular weight heparin, which is therapeutic or high dose, and subcutaneous heparin again high dose, more than 10,000 units per day. 24 hours is low dose of rivaroxaban. 24 hours, which is unique. Low dose rivaroxaban is different. 24 hours. 24 to 48 hours is epiximab, again antiplatelet agent. 36 hours is low dose fondaparinux for young and low dose epixaban. 42 hours is low dose fondaparinux for elderly. Only elderly, no renal dysfunction. 48 hours straight fizz cilastazole, again antiplatelet. 58 hours is low dose fondaparinux, moderate renal insufficiency. 70 hours is high dose fondaparinux, young patients with normal renal function. 105 high dose fondaparinux, elderly patients with normal renal function. And 72 hours is high dose apixaban, rivaroxaban, edoxaban, dabigatran. This is where everybody is okay. 72 hours, high dose of all DOAC, apixaban, rivaroxaban, edoxaban, dabigatran. 120 hours, सबसे ज़्यादा किसका है? High dose dabigatran when there is low creatinine clearance. 5 to 7 days clopidogrel and ticagrelor 5 days, prasugrel 7 to 10 days, and contraindicated are DOACs and parenteral thrombin inhibitors. Avoid neuraxial, not DOACs. DOACs में तो दे रहे हैं. Parenteral thrombin inhibitors and fondaparinux in severe renal impairment. ठीक, fondaparinux in severe renal impairment. नाउ यू माइट बी वंडरिंग कि सर ये क्या है, या आपने क्या लिखा दिया. तो देखो ऐसा है कि जो अनइम्पॉर्टेंट वाले हैं, जैसे कि आपका हो गया fondaparinux, नॉट वेरी इंपॉर्टेंट, सिलास्टोजोल नॉट वेरी इंपॉर्टेंट, then you have cangrelor, not very important. See, most of the time the idea would be the anticoagulants, which is your rivaroxaban, your epixaban, your edoxaban, and your dabigatran. So if at all you have to remember, at least remember the unfractionated heparins, the low molecular weight heparins, the warfarin, prasugrel, clopidogrel, aspirin, and your oral anticoagulants. These are the mandatory. Baki antiplatelets में tirofiban, eptifibatide, cangrelor and epsiximab, if you can remember, fine. Fondaparinux का सब चीज उल्टा है. So if you want to remember it as a unique point, then that is also fine, right? So I told you I'm going to discuss ASRA in detail, and I would want you to go through this and make notes of this. And this is what you have to reproduce in ASRA, and this is the entire guideline. I'll send you the PDF, and I hope that this has started to make some sense to you. ASRA is something which everybody will keep asking you for your entire life, and that is why I have taken this effort to give you ASRA in a very, very easy form. Do let me know if you need any more help, or if you feel this is too complicated. I'll try to again do something about it, but I feel this is the best I can do with the guidelines that are anyway very twisted, right? So thank you so much, and God bless you all.